Welcome and good morning, everyone. You have logged into Best Doctors for Physicians by Physicians webinar series. My name is Eric Glazer, and I help lead physician engagement and social media at Best Doctors. And our topic for today is entitled Clinical Application of Whole Genome Sequencing, the Future of Diagnostic Accuracy. I am joined by an esteemed panel of experts, all of whom we will formally introduce in a moment. Today's session is being recorded and will be available on demand. For those of you who have never heard of Best Doctors before this morning's webinar, I want to clarify briefly what we do. Best Doctors brings together the best medical minds in the world to help identify right diagnosis and treatment for patients. We have an innovative peer-to-peer consultation service that offers a new way for physicians to work together with other physicians to ensure that the patient receives the very best care. Back in 1989, we were founded by two Harvard Medical School professors, and we now serve nearly 30 million members in over 70 countries, and we are now deemed one of the world's fastest growing healthcare companies by publications like Modern Healthcare and Inc. magazine. We're often asked how we identify our experts or our quote-unquote best doctors. We do this based on a specific peer polling methodology that enables us to recognize the leading physicians in each specialty so they could potentially be part of the collaborative medical process and expert consultation that we provide. So we don't sell advertising and we don't ask doctors to pay to be on our list. We make our money by being integrated as a trusted service into the benefit programs and healthcare offerings of large employers and health insurance companies, most of whom you've heard of and know. So Fortune 1000 companies like Pepsi and Home Depot and Procter & Gamble, they'll hire us to assist their employees in providing comprehensive medical advice. And over the past 20-plus years, we've developed and refined a collaborative process that allows the leading physicians, our best doctors, to work cooperatively with each other and our internal medical team to provide patients with the best possible advice and insights. I want to just take you through very quickly how we do that. We call this an interconsultation. In brief, we have trained nurses in-house, most of whom have over a decade experience at leading teaching hospitals, and they do a full patient intake. And we also collect all the medical records and rerun pathology if necessary, rerun radiology if necessary, and then have one of our internists synthesize the case and author what we call a clinical summary. And this is a in-depth 4 to 12-page overview of the case, but we don't go about answering anything at this stage. We actually ask our internists to only ask key questions around the case. And then we take that clinical summary that's been written by our doctor and we send this to an expert physician, someone within who's been elected a best doctor expert who our nursing team deems is an appropriate case match for the case. And that's who we contact, so many of you on the phone today, to look at our clinical summary and write us what we call an expert review, which is essentially a detailed write-up of answers to the questions that we posed. And then we QA that with our internal medical team, and then we eventually send that back to the member, and with the member's permission, of course, we get it to the treating physician. So that's what we do. Our organization's purpose is completely focused on helping physicians help their patients ensure that they have the right diagnosis and right treatment. As I stated earlier, we were founded by physicians, and today our organization is driven by the passion of our physicians and nurses here in trying to make a true positive impact on people's lives. And as part of our mission, we're going to continue to provide resources to educating physicians in all areas associated with diagnostic accuracy and clinical decision-making. We have been, this past year, doing monthly webinars on areas tied to diagnostic accuracy, tied to coordination of care and communication, including social media. All our webinars are available on demand, and all of them are available to you. So just so you know, there's resources if this is your first webinar that you could go to retrospectively, and we'll continue to produce these moving forward as well. You know, and as technology has evolved, there'll be just more opportunities to further grow and enhance the medical process, and we want to try to push ahead of the curve in engaging you, the medical community, around opportunities that technology presents in being the very best diagnostician. So as such, we're really excited to present to you this morning a tremendous panel of experts who are going to talk to you about how genomics is becoming current and a reality, and how it's going to be a predictive or more a diagnostic tool for all of you. The costs of genomics are continuing to go down as technology has advanced. We are closing on what's been called this long-awaited future. And in fact, we'll probably have some experts that you'll hear from today who will argue that the future is already here. And as physicians and researchers are talking a lot more about genomics, there's a strong agreement amongst the medical community that as technologies continue to evolve, personal genomics will have a very positive impact on patient care sooner than later. So very quickly, we're going to, as an attendee, you're in listen-only mode, but we want to encourage you to be asking questions throughout today's session. So there's a Q&A module on the right-hand side of your screen, and throughout today's panel discussion, feel free to input questions. We will try to take them and answer them either at the end of today's session. We've allotted about 10 minutes to go through questions from all of you, or if it's relevant to the discussion, I may interject and pose your question right to the panel within the flow of today's discussion. And incidentally, we are scheduled to go to 8:30 here on the East Coast, so we're pretty prompt. We know you have patients waiting to see you, so we'll end on time. But in addition to asking questions of us, we're going to ask some questions of you through a little bit of what we call our attendee poll. So you'll recognize the attendee poll on the lower right-hand side of your screen, so be on the lookout for questions that we'll ask all of you related to the topic, and that will be a fun, neat way of showing what the audience thinks. We never reveal individual identities. We only show the data in aggregate, so there's no worries there. To lead our esteemed panel, we've brought one of the most well-versed and knowledgeable domain experts in genomics and genetics here to moderate. His name is Dr. Kevin Davies. Kevin is the editor-in-chief of a publication called Bio-IT World, and he's also the author of multiple books on genomics, including his most recent title, The $1,000 Genome. You will not meet anyone who is more in touch with current technologies, current organizations, and current leaders in the research around genomics, and he's the perfect person to lead us today. So Kevin, I'm going to hand over the presenter ball to you and let you take it away.
Thank you very much indeed, Eric, and good morning, everybody. My pleasure to be here. Eric and I were colleagues in a recent past life, and I'm looking forward to a very fun discussion. Let me stress, I'm a doctor of philosophy, not a doctor of medicine, but the four guests who I will introduce in just a few minutes are all MDs and really at the forefront of integrating the stunning progress that we're seeing in genomic technology and analysis into medical practice. And we've got several questions for them, which we will get to in a few minutes, and encourage you, as Eric said, to enter questions into the chat dialog box. Let me just quickly try to set the stage for what we're going to be discussing this morning. You've already seen a version of this graph produced by the folks at Best Doctors. This simply serves to sort of divide the world into sort of the pre-genome and post-genome era, if you will. Before the Human Genome Project was declared complete in the 2000-2001 timeframe, progress on genetics, in retrospect, was incredibly slow. We, and I was one of them for a while, spent years and years searching to find the crucial disease genes that cause diseases like muscular dystrophy, cystic fibrosis, Huntington's disease, and many others. Literally years, hundreds, thousands of man-years spent trying to map these genes before they could be isolated, because we didn't have a map to guide us. And then in about 2000, many of you will recall, President Clinton declared the first draft of the Human Genome Project complete, and that, for the first time, provided us with an encyclopedic reference of the genetic code divided across our 23 pairs of chromosomes. And from there, the science really took off. We were able to produce maps of the human genome, maps of genetic variation. We were able to devise technologies such as DNA microarrays to interrogate genomes. We saw the arrival of direct-to-consumer genomics, companies like 23andMe and Navigenics, that could provide a sort of a genomic survey for individuals by means of a simple spit test. But it's really the progress in next-generation sequencing, as it's so called, that has really turned genomic medicine on its head. And you can see from this graph, which plots the cost per human genome, that in the immediate aftermath of the Human Genome Project, we were still in the tens, if not hundreds of millions of dollars for a single human genome. That was the cost of the first Genome Project. But starting in about 2005, 2006, we saw the first commercial launch of new next-generation sequencing, or NGS technologies, from companies such as 454 Life Sciences, which is now part of Roche. And then two companies really took over and still dominate the market, Illumina and Life Technologies, both publicly traded, both headquartered in San Diego. And as you can see from the graph, come about the beginning of 2008, the instruments developed and released by those companies really transformed genome sequencing to the point that now researchers and increasingly physicians can gain access to complete human genome sequences for just, at today's price, just a few $1,000s. It takes typically about a week to develop a whole human genome sequence, but we're seeing even faster technologies on the very near horizon, and I will touch on one in just a second. The poster child for, that's all very well and good, I'm sure you're thinking, but what does this really mean for medicine, and has it had any impact? Well, this young boy, a very brave boy from Wisconsin named Nicholas Volker, is arguably, I think, the poster child of clinical genomic medicine. A few years ago, he was in hospital in Wisconsin. You can see he had a very severe intestinal ailment which had not been diagnosed. And finally, his pediatric gastroenterologist contacted a leading genomics researcher in Wisconsin, at the Medical College of Wisconsin, and said, Howie, we're at our wit's end. We don't know what else we can do for this little boy. Do you think we could analyze his DNA? And I mean sequence his entire DNA. And Howard Jacob, the physician that was contacted, said yes, after a fair amount of thought and consultation with his colleagues. They sequenced not his complete genome, not all 6 billion bases, but they took a shortcut, which is convenient and still very popular today, which is to look at the exome, which is simply sort of using a molecular magnet to pull out all of the genes in our DNA. We obviously have a lot of so-called junk DNA that you're aware of, which is perhaps less relevant in this sort of context. So they looked at the genes, and to cut a long story short, they found a specific mutation that caught them by surprise, but made sense in the context of the patient's disease. More importantly, this particular mutation had been seen in a handful of other patients that would have rendered the boy very susceptible to Epstein-Barr virus infection. A bone marrow transplant was promptly warranted and ordered, and as a result, the child is now absolutely thriving. These photos were taken earlier this year. He's back home. He's eating healthy food, normal food for the most part. He's had no complications to speak of, and last year he went trick-or-treating for the very first time. There have been many other cases since then, but I think Nicholas still stands out as the shining example of where this field of whole genome sequencing can go, particularly where we are trying to end a diagnostic odyssey and we don't know what else to do. Another field that is really seeing a tremendous impact of genome sequencing is in cancer, not surprisingly, and this is with permission from a company in just up the road from us in Boston called Foundation Medicine. This is an example of an iPad screen or a medical report that would go to a physician that would be working with a company like Foundation to do a complete molecular profile of a patient's tumor. So a biopsy can be sent to Foundation Medicine. It will be the DNA will be extracted, genes, about 200 100 documented cancer-related genes will be analyzed in the tumor, and using a series of proprietary algorithms and analysis, the result that goes back to the form that goes back to the physician includes the molecular profile of the tumor, which you see in red there, a list of potential drugs or therapeutic agents that may be most relevant for that patient's unique tumor, as well as clinical trials in the area that the patient lives that may be worth the oncologist investigating. So I think that's it for my introduction, and I'm going to introduce four esteemed guests to take us through the rest of the discussion and discuss with us what impact they see these new genome technologies having on medicine. Four guests, all of them MDs, all of them extremely distinguished. Let me introduce them now. Mark Boguski is a pathologist and a hugely distinguished bioinformatician who has worked over the years at the NIH. He was the founding director of the Allen Brain Institute in Seattle. He had a stint in Big Pharma with Novartis before coming back to Boston a few years ago and joining the Beth Israel Hospital and the Center for Biomedical Informatics at Harvard Medical School. He's also the founder of an important and very timely new consulting practice called Genome Health Solutions. Joining Mark on the panel is Kent Bottles, who is a much sought-after keynote speaker and consultant specializing in the future of healthcare and healthcare leadership. In biotechnology, Kent has served as the president of the Genomics Repository, as well as chief knowledge officer and managing director. So Kent, welcome to you. Mike Thompson is the medical director of cancer research at ProHealth Care Regional Cancer Center in Wisconsin, as well as the clinical trials lead investigator of the NCI Community Cancer Centers program. He has a PhD in pharmacogenetics, did his residency at the Mayo Clinic, and holds fellowships at both health fellowships at both the NCI and the MD Anderson Cancer Center. It's a pleasure to have Mike joining us today. And last but not least, Arnold Palay is the medical director for the Changebridge Medical Associates and director of primary care genomics for the Personalized Medicine Institute of the Atlantic Health System. Arnie is based at Morristown Hospital in New Jersey. He also serves on the Finance and Insurance Commission for the American Academy of Family Physicians. So good morning, gentlemen. Look forward to a robust and vigorous discussion. And I think we're going to start talking about I'm assuming you agree with the premise of our webinar and the outline I've just given, that improvements in access to exome and whole genome sequencing are rapidly approaching the clinic, which must scare the bejesus out of many people on this call, because that's an awful lot of information to handle, to interpret, and in many respects raises simply far more questions than it could potentially answer. So I wonder, to kick off, what barriers do PCPs, and maybe we can broaden that to physicians in general, what barriers do they face in communicating genetics information to patients? How can geneticists make PCPs a partner in personalized medicine? I wonder, Arnold, if you'd like to take first crack at that.
Well, by all means, thank you, Kevin. I appreciate that. So I kind of wear two hats on the panel. I am a primary care physician by training, and in addition, I practice genetics, genomics for the last number of years as well. And the problem is many levels. Obviously, everyone knows there's insufficient training. The physician community, particularly in primary care, but with our specialty colleagues as well, are just not well trained in genetics. There are discussions, if you're 5 years out of medical school, you know almost nothing about genetics, given the charts that Kevin showed before with the rapid explosion of information. But in addition, residency programs are not well focused on genetics. It's just not something that's given sufficient attention to. Faculty are often not, well aware of the areas of genetics. Jargon is a big problem. The language of genetics is so complex in many cases that many physicians feel put off, perhaps. But a brief refresher course of understanding basic language is something that I would start with, would be immediately helpful for their genetics colleagues to do that. And that's the kind of thing we're trying to do at our center down in the New Jersey area, to get physicians aware of language of genetics. There's lots of lack of triggers, as I say, for incorporating the usage of genetics. A lot of times a physician in their office, busy seeing patients, often will not know to even consider genetics given the situation that their patient presents with. So they're used to, ordering biochemical marker tests, obviously taking a detailed history and physical. But let's just talk about a good 3-generational family history. It's just remarkable how electronic health records are completely lacking in most cases with a careful, precise 3-generational family history with attention particularly paid to onset of conditions so that the clinician would know to consider that 1, 2, 3 family members have something that could be genetic, to even consider the possibility of having genetic testing ordered if appropriate or referral to a properly genetics-oriented provider so they can then take the ball and run with it. So these are some of the issues, Kevin, that I've encountered in my work that is trouble for the clinicians in the particularly primary care world.
Excellent, Arnie, and I'd be curious to hear how you're using genetics in daily practice. We'll come to that in a few minutes. So let's bring in the other panelists. Mark Boguski from Beth Israel, welcome. Give us your perspective.
Well, I completely agree with Arnie about this. Many physicians don't even know how to record an accurate and detailed family medical history. And as we teach our residents at Beth Israel, a good family medical history is still much more powerful than any genotype screen for predicting disease susceptibilities in a patient. I'd like to illustrate that with one kind of tragic case. I recently was consulted on a 36-year-old man with metastatic, he just presented out of the blue with metastatic colon cancer. And as everyone knows, colon cancer is more of a disease of the elderly. And as soon as I heard this patient's age, I immediately concluded that there must be something going on in his DNA, and the family needed to know about that so they could be appropriately tested either by genetic testing or just colonoscopies. And from my understanding of the case, no one had ever told this patient that there could be something in his family that would cause early onset colon cancer, and it turns out after this became known to the family member, 20 people got colonoscopies. Precancerous polyps were found in a subset of them. The family has Lynch syndrome, and some of these family members were only 42 years old and would not have been eligible for colonoscopy until age 50, by which time some of these polyps could have turned into cancers. So I think that's a pretty shocking example of just sort of a basic lack of knowledge on how to do a family history and what the implications are for individual patients. We started a mandatory training module in our pathology residency program at Beth Israel about 3 years ago on genomics and personalized medicine, and all of our residents, our second-year residents, are required to take this. We also incorporated into it a well-known teaching tradition in medicine, sort of see one, do, and teach one, or practice on yourselves. And so we offered our residents an opportunity to have themselves commercially genotyped so that they could put themselves in the patient's shoes. And that was very enlightening for them. In terms of some basic definitions and labels and things like that Arnie talked about, we did prepare a little blog post today with some basic definitions in it. You can find that at curbsideconsult.tumblr.com. Please have a look at that because it defines genetics, genomics, and all of that. Lastly, the thing I'll say, Kevin Davis brought up the example of foundation medicine, which is really a mover in the field. However, the foundation medicine test, to the best of my knowledge, costs around $5,600 to look at 200 genes and is not insurance reimbursable. So this notion that we can do a whole genome for $1,000 doesn't mean that that's going to be the cost for an actual FDA-cleared diagnostic test that someday gets reimbursed by insurance companies. So genetics on that level, or genomics on that level, is still very much for self-pay patients, and you have to sort of know someone to get access to the technology.
Yes, thanks, Mark. I mean, I would add, I think the whole interaction with the health insurance companies is obviously a moving target. There have been anecdotal reports of some genome sequencing operations, specifically in the Medical College of Wisconsin, where insurance companies are offering reimbursement on a case-by-case basis, but clearly it's just the beginning. Let's talk to Mike Thompson, speaking of Wisconsin. Mike, welcome.
All right. So I think it's very useful that it's already been stated that family history is critically important. And at our center, where we have a cancer center, we have 2 genetic counselors. And it is, even for people that are aware of it, it is very difficult to take the time to not only dig through that person's history, but it's an iterative approach where I can't remember my family history, and it's usually you have to go and dig, and it requires an iterative approach to build a very strong family history. And the onset and all that is something that should be put in the EMR and can track with someone, but is difficult to do. So I think family history is huge. The question about PCPs is they're time limited. So if you have 10 minutes to see someone, or even half an hour, and you have to go through multiple things, knowing detailed family history and genetic equivalencies for phenotype might be very difficult. As mentioned, genetics is moving quickly, and pharmacogenomics is moving quickly, and even people in the field that are, have dedicated time just to keep up with the literature have difficulty with it. So a primary care doctor who's seeing diabetes, asthma, heart disease, it's very difficult to do that. There are potentially liability issues where people now are referring off to subspecialists for stuff even that they can handle, partly for liability issues, that they're worried that if they miss something, no one will give them credit for solving a complex case that they have very little time to do, but if they do anything wrong, they'll come after them. So I think some of the issues are that primary care doctors, like I think all doctors, need structure and need help with transitions of care. So ideally there's a system, whether that's an external system like one of these consulting groups or Best Doctors, or an internal system for larger programs that can seamlessly share this data and give it context. Some of the issues in our genetic counseling program are, if you get either exome sequencing or whole genome sequencing or whatever sequencing you get, how long are you reporting on that? So if you get some testing done now, and 2 years from now there's new data available regarding mutations which weren't known at that time, are you responsible to track down the patient that you once saw, and how long does that responsibility lie? So what I have heard is that some places will say, here is your genetic counseling up to this point in time. If something changes, you are responsible to come back to us to find stuff, because tracking down hundreds or thousands of people that move and change addresses and phone numbers might be very difficult. So certainly a primary care office is going to have difficulty with that.
Yes.
And then just understanding how to relate it to specific conditions. Even the subspecialists are having difficulty with that. So I think it's going to be about integrated approaches with intelligent reporting and contextualization, and that might come from one company or it might come from general approaches.
All right, and finally, let's bring in Kent to talk about this topic.
Hey, before Kent goes, this is actually a perfect segue because he's one of our social media guys. I failed to mention, everyone, we are tweeting live with the hashtag MDChat. Now, I know that's probably a foreign term to most of the folks on the call, but for a few of the people who actually use Twitter or are on Twitter, just so you know, we're tweeting today's session via MDChat, the hashtag MDChat.
All right. Kent, talk to us about the challenges and barriers that PCPs face in communicating genetics to patients.
Yeah, I teach health policy at the School of Population Health at Jefferson University in Philadelphia. And I guess I see it from 100,000 feet a little bit differently. I think one of the things I'm really glad Mike mentioned was genetic counselors, because I think all of us in medicine are going to have to become much more team-based. I mean, we've all heard Atal Gawande say that we need to train doctors not as cowboys but as pit crews. And certainly genetic counselors are going to be a huge part of the solution of removing barriers. The other thing is that primary care, I think, is going to change.
And I think you're going to have to include nurse practitioners and PAs and other folks, maybe even sociable humanoid robots, in looking at algorithms that can help us make sense of all this. Another thing I think that hasn't been mentioned is privacy concerns. We're really perfectly timing here because the Presidential Commission on the Study of Bioethical Issues has just issued 12 recommendations on what it means to strengthen privacy of patients in an era of whole genome sequencing. So privacy is a huge issue. It was mentioned about problems with family histories. There have been a couple of lawsuits where actually there's HIPAA privacy concerns about whether the doctor who treats the patient with the colon cancer can reveal evidence of that to the rest of the family, or whether there's privacy concerns there. So again, there's a huge cultural dimension that has to be talked about. I'm glad someone mentioned the cost, because right now the average doctor and the average patient really can't get whole genome sequencing. And finally, I guess I'd say, there are barriers that are structural. I mean, it's a great story to talk about that we're going to do a whole genome sequence of our normal DNA and of our tumor DNA, like Steve Jobs did when he had his pancreatic cancer. But if you think about that, there's a problem. A recent article in the New England Journal of Medicine showed that for 4 renal cell carcinomas, it depended on what part of the tumor you sampled, depended on what mutation you revealed. So it's not like you can just take one sample from a tumor and say that's the driver mutation that then you treat with personalized medicine. So as always, nature is a lot more complicated than we think. And although we know a lot about this, it's not at all clear to me how much is actionable at the bedside right now in primary care.
Excellent. Well, let's talk about, let's move on to our next question and talk about how genetics is being applied in your practice, in your sphere today, before we kind of project ahead and give us some thoughts on where we see this going. And you've already raised, all of you have raised some very fascinating issues and challenges in implementing the advances in genetics. We're obviously not offering routine exome or whole genome sequencing today, although there are certainly more and more facilities where those, particularly exome sequencing, is available from academic health centers and some diagnostic companies. But let's focus for the time being, for this next question, on examples of utility in the present day. What are the sort of most common or perhaps useful examples of genetic diagnostics in your area of expertise and your institutions? Is it, for example, e.g.EGFR testing in cancer? We've got a number of cancer examples on the screen here. Or are you finding it useful in other areas, Alzheimer's or other diseases, perhaps? So, Kent, I'm going to start with you.
I guess as a pathologist, what I'm most excited about is the way that we're redefining cancer as not a disease of organs, but as a genetic disease. I mean, as a pathologist for years, we've said there's prostate cancer, there's breast cancer, there's lung cancer, and that's how everything was classified. I think the recent studies that have shown, mostly in lung cancer, that what looks like an adenocarcinoma of the lung to the pathologist histologically turns out to be quite different if you can identify what is the driver mutation. And then the Nature article that just came out a few weeks ago, subclassifying breast cancer into 4 types, based on genetics, is very exciting. And one of the rarest types, it turns out, has the same genetic mutation as some ovarian cancers and some lung cancers. So would it make more sense to not talk about lung tumors or breast tumors, but to talk about that these 3 types of tumors, from the ovary, from the breast, and from the lung, should be classified together based on their genetics? And I'll let maybe Mike or others talk about that a little bit more. I think maybe just as exciting is pharmacogenomics. I mean, a great example, I think, is Plavix, which we all know is a drug that's used to prevent clotting of coronary artery stents. And there's a single small variation in that gene greatly can reduce the clinical response to Plavix. So the idea that you could use genetics to figure out and personalize the dosage for a drug is very exciting. Although I would urge caution, because epidemiologists often think that the variation in the response of patients to a drug can be random and may not be due to genetics. And I guess the other thing I would point out that I'm excited about is the Mayo Clinic and Cincinnati Children's Hospital. There are studies on cytochrome P450 superfamily of genes and how they can personalize drug use in mental illness. Even though we don't really understand the causes of the mental illness, the GeneSight therapy test for 5 genes has allowed physicians to tailor drug therapy to 12,000 patients' individual metabolism. So I think that I'm most excited about how it's changing the classification of tumors, and I'm also very excited about the use of pharmacogenomics in tailoring the dosage and kind of drugs that you give to every patient.
Excellent, Ken. Thank you. Mike Thompson.
So I think in the area of genomics or personalized medicine, cancer often comes up because the therapeutic index. So the drugs we use often have high toxicity, and if there's changes in either metabolism or their effect, it's a big difference. So if you have a pneumonia and your antibiotic will work, even if the dosage and the amount in your blood is different, it doesn't really matter. And many things in medicine, we don't need to be that personalized. But in some areas, including probably cardiology, cancer, neuro, I think it's going to be highly important, or potentially chronic diseases which we're not identifying. But a couple of concepts. So in cancer, we heavily use genetic and molecular marker testing now. And I'll go through some examples, but we are not really using genomics. So there are some different definitions, but to me, genetics or pharmacogenetics is looking at one gene or a few genes, including when you're doing like Oncotype DX testing or some of these panels, it's really looking at a few genes. And if you're looking at the whole genome or subsets like the exome or large subsets like in arrays, I think that's genomics. Ken said something interesting about disease versus mutation, and back when I was a beginning fellow at MD Anderson, I remember they talked about having departments that were based on, like, are you a BRAF doctor, are you a BRCA doctor, EGFR doctor, and that's partially how things are evolving, but I don't think it will ever get completely there. So we know that if you have a BRAF mutation in melanoma, that you will you have a high chance of responding to a BRAF inhibitor. But if you have a BRAF mutation in colon cancer, BRAF inhibitors don't work. And other things where we found BRAF inhibitors or BRAF mutations, including hairy cell leukemia and myeloma, it's questions that are up in the air. So there is a difference between bystander mutations and driver mutations which drive the tumor, and the context of a mutation is going to be different in different tumor types, such that even if that is a driver mutation, some cancer cells may be able to get around it if you inhibit that. So that's some of the complexity. Also, I think the heterogeneity explains much of our confusion and difficulty in medicine and in cancer. So sometimes we'll give someone a cancer drug and we'll see some things shrinking and some things are growing. And so we say it's a mixed response, but actually the cancers that have the target are shrinking and the cancers that don't aren't. And part of that will be utilizing, it's going to be hard to biopsy 100 nodules, but we might use things like theranostics where we have molecular imaging looking at targets, and we can say, is this part of the 25% of people that have high heterogeneity, for instance, in breast cancer,
yeah,
or does this tumor look pretty homogeneous and we think this target is going to work completely? And so we're going to get, it's going to be hard, it's going to be very difficult and subtle, but we're going to get better eventually. But some of the genetic tests we use are mentioned there, but e.g.EGFR, KRAS in colon cancer, HER2 in breast cancer and stomach cancer, BRAF, as I mentioned, ALK testing, now ROS testing in non-small cell lung cancer, and there are differences between predictive tests, like I just mentioned, and prognostic tests. So BRAF is not predictive in colon cancer, but is prognostic, and there are some things we aren't using that much, like COX-2 testing in lung cancer, and then pharmacogenetic tests, which really, even in my area, are known about but minimally used, such as DPD, UGT, cytochrome P52D6. And so all of these things are highly interesting, but some of them still need validation. And then in the non-cancer world, there's things like cytochrome P450, 2C9, and the vitamin K receptor for warfarin metabolism, which have been studied, I remember back when I was a grad student, so at least 10, 20 years. And while they show some predictability, in clinical practice, they tend to, basically people have voted with their use and haven't been using them because they can, by other methods, in this case an INR test, can adjust even if they don't get it right the first time with little negative clinical outcomes. So it's an interesting world, but it's going to be more complex, and going back to the primary care doctors, it's just way too complex for them or even some subspecialists to do, and we're going to have to develop systems to deal with the huge deluge of data. And I was down at Arizona this weekend giving a talk, and my friend from TGen, where they do a lot of sequencing, told me that it takes them, a few weeks to get the sequence, but 8 weeks to analyze it, and in some cases even longer. So the informatics is a bigger barrier than the technology of getting the sequence now.
Yeah, I think that's going to change, but it's certainly it's in the interpretation at the moment where much of the bottleneck is. Arnold Palay from Morristown in New Jersey.
Well, obviously one of my goals of being a teacher to primary care physicians, particularly both locally and nationally, on the incorporation of genetics in day-to-day usage. While I agree with Mike from some of his comments, it's difficult. The fact of the matter is that we in primary care day-to-day stratify risks and try to determine who has what conditions so they can be properly handled, and if appropriate, get our specialty colleagues to assist us. So I don't know if the slide is up in front of everyone now. I just gave some examples I usually provide in daily medical practice of the kinds of testing that could be considered. It's not to make a PCP an expert in all these areas, and I would agree with Mike, it's complicated, but it's one of those adages like if you don't think ectopic pregnancy, you'll never diagnose it. If you don't think about some of these examples for genetics, you'll never consider it. So BrCA is well known, and obviously it's become almost mainstream for most primary care docs, particularly OB-GYNs, who will use it a great deal. But then there are other examples. The pharmacogenetics already mentioned, clopridogrel, C2, C.9 is certainly something to be considered. It's a black box warning people should consider. I really enjoy elegant studies in something like prostate, number 6 on the slide, that we all know PSA is a horrible screening test for prostate cancer, but men come in every day considering, do I have prostate cancer, doc? And the fact of the matter is that there are prostate genetic alleles, SNP tests that can be considered in addition in certain appropriate circumstances. A change of velocity in a PSA can have a PCA3 urine test done, and that is a test that very elegantly could identify gene expression of prostate cancer and can be a remarkable tool, particularly for the younger male who's not even remotely considering prostate cancer, to get them to move forward and get a prostate biopsy. And I have other examples, KF6, there's several cardiac markers that are being used nowadays. The point is that you have to just get yourself aware very vaguely in the primary care arena and know to refer, if you're not able to do this yourself, to someone, like myself or other geneticists specifically who are aware of these types of tools to assist them. Because if the primary care physician were to ignore this completely, then these patients will never be found, and that's the key element that has to be made. Thanks.
Okay, thanks, Arnie. And finally, Mark Boguski.
So I'm glad that Kent mentioned genetic counselors. We use genetic counselors to team teach our curriculum for pathology residents in personalized genomic medicine at Beth Israel, and they've been a really key component of our efforts. However, there's only 3,000 genetic counselors in the entire United States. There's simply not enough of them to meet the demand. In fact, there's only 1,000 medical geneticists in the United States. And so to think that we can just refer all of these cases to colleagues of that nature is kind of unrealistic. The other thing I'll add is that medical geneticists, for instance, typically their training consists of learning about pediatric onset Mendelian disorders, and most applications of genomics right now are, in adult onset conditions or used for prognostic and predictive testing. In terms of potential workforces for genomic medicine, I already mentioned the paucity of genetic counselors and medical geneticists. But I'm glad Kent's a pathologist, so am I, because pathologists can be your best friends here for the primary care practitioner. There are 17,000 pathologists in the United States, And through our efforts at Beth Israel and through the College of American Pathologists, those pathologists are rapidly coming up to speed on fundamentally what's a laboratory test. Any genomic assay, any genetic assay has to be done in a CLIA-certified laboratory. Pathologists know a lot about how to interpret those and do quality assurance, quality control. The other thing I'd like to say on this subject, though, is that we heard some examples from Kent and Mike about finding mutations in tumors that you would normally expect based on our traditional organ system classifications of diseases. And those findings often suggest novel therapeutic approaches. Most of these approaches, though, are the off-label use of FDA-approved drugs. There's a very well-known case that was published in the New York Times a few months ago about actually a hem-onc fellow at Washington University in St. Louis who got ALL, and to suppress the tumor prior to his bone marrow transplant, he had genetic testing done because Washington University is one of the big centers that does genomic analysis, and a novel target was found in his leukemia that suggested that a drug normally used for renal cell carcinoma could be effective in suppressing his leukemia prior to bone marrow transplant. The problem is that no one would pay for the off-label use of that drug, and the patient himself had to pay $330 a day for a 12-week course of therapy in order to make himself eligible for a bone marrow transplant. So the economic issues here are considerable, and the fact that physicians are going to have to sometimes exercise their legal authority to prescribe off-label if they're going to bring the benefits of targeted therapy based on precision genomic diagnostics.
Thanks very much, Mark. And I'm going to bring you back in just a second for this final question that I have, and I'm sure Eric will encourage any questions that we have from the audience. If this discussion is prompting any issues or questions you'd like the panel to address, do quickly enter them into the chat box on your screen, and we'll try to squeeze them in before we wrap up at the bottom of the half hour. That's a fantastic survey that you've all given about where genetics currently is in the clinic. I want to encourage you to sort of put on get your crystal ball out and just sort of guide us through how you see this field evolving in the next 2 or 3 years. We have already seen in the last 12 months, I would say, a growing number of medical centers offering exome sequencing now to their constituent members and beyond. Places like Baylor College of Medicine, Emory, UCLA, Washington University, and others all offer now exome sequencing, which is when you sequence the 2% of the DNA that corresponds to our genes. This service is also available from molecular diagnostic companies. Ambry pioneered this last year with their Clear Exome test. I'm wondering if you think it inevitable that as the prices continue to fall, we're already at the point where exome sequencing, the price of that matches or in some cases even undercuts the commercial list price of gene panels for ataxias or different disorders. How do you see this changing medicine and improving the diagnosis of a whole slew of genetic disorders as well as cancer? Mark, I'd love your thoughts on that to kick off.
Sure. A couple of comments. First of all, molecular diagnostics are typically defined by 2 attributes, a technology platform and a proprietary set of reagents. So for instance, a fluorescent microscope and probes for fluorescence detection of genes or gene rearrangements. And so we have all of these pairings of technologies with reagent sets. I think the promise of massively parallel sequencing is that we could transform molecular diagnostics into from a combination of technology platform plus reagent set into simply one test at the basis of it, and the distinguishing features between one molecular diagnostic and another will simply be software filters applied to whole analysis. That being said, exome and genome analysis is being offered in a number of places now. However, it's important to realize that most of the instruments that are being used today are not FDA cleared for diagnostic use, and all of the results coming out of these instruments have to be stamped with the warning for research use only. Now, of course, it's up to the physician and the patient decide to make a medical judgment and act on an information, but the data coming off these machines is strictly for research use or investigational use only, according to FDA terminology. And we already talked about the lack of insurance reimbursement for most of this. I think the way forward is to conduct formal comparative effectiveness research studies where we compare standard of care FDA-approved diagnostics in parallel with whole genome or whole exome analysis and look at the quality and cost and turnaround time and clinical utility of these tests. And only then will we be able to make the case for broad-scale adoption and insurance reimbursement.
Excellent. Arnold, let's bring you back in.
Sure. Well, I think right now we are in an interesting holding pattern of sorts. You know, we have seen, as you said, the precipitous drop in price, but we have not seen the concomitant ability to have the accuracy and the applicability of these tests made for day-to-day, despite some small examples I provided previously. So the problem is, I think we need to have a catch-up period right now where more and more there'll be studies and reproducibility of results to apply to day-to-day usage before the regular day-to-day application by primary care physicians in their office becomes more paramount. However, coloring that is an interesting phenomenon. The patients are interested in genetics. At my large hospital system foundation, the #1 issue I'm always asked to speak about is genetics. They're just really intrigued. They read the New York Times, Wall Street Journal. So that will propel, I believe, the genetics situation and usage in the world of clinical medicine as that holding pattern starts to become more available, as my colleagues have said, and as we start getting examples that are reproduced and in the major journals become evidence-based. I believe the community of patients out there will demand of the doctors, what about my genetics? And so I think in the not-too-distant future, another key arm in the world of primary care and in subspecialty medicine will be the good history, physical, biochemical test, and genetic screenings with family history will become a regular part, perhaps 5, 10 years down the line.
Right. Kent and Mike. Kent first.
You know, I take one step back and say I think this is incredibly important and exciting, but I think it's just one of many developments that's going to be a convergence that's going to create digital medicine. And I guess I'd quote David Agus, who's an oncologist at USC. It's important to approach your health in general from a lack of understanding. Honor the body and its relationship to disease as a complex emergent system that we may never fully comprehend. And I guess what I mean by that is that I think that all the things we've talked about are very complicated. We don't really understand everything. Just one example is, you know, the epigenome or epigenetics depends on the shape, the folding of the DNA. You can have the exact same DNA sequence, and sometimes things get expressed and sometimes things don't because the way the histones and methyl groups attach change the shape of the DNA, making some sets of genes accessible and others inaccessible for transcription. The other thing I would say is I don't think it's all just genetics. I'm very excited about a new thing that's coming out of the NIH, the microbiome. I mean, each of us has over 100 trillion bacteria in our bodies and around our bodies that are actually now being thought to change the way asthma develops or obesity. And these bacteria that we live with have at least 4 million genes. And so the way that they work, and just one example, the kind of bacteria you have in your stomach changes the kind of hormones that you have and seem that they may have a big component to the obesity epidemic. So I think that the big data approach is going to be huge, and the whole genome sequencing is just going to be one part of things that have to be put into algorithms to help us take better care of patients. It'll be not just genetic information, but microbiome kind of things, and then also social media, how we interact with other people. So I think it's more complex than just genetics or genomics in isolation.
Thank you. Great point. I hope we can come back to the microbiome at a future Best Doctors webinar. Finally on this question, let's bring back Mike back into the conversation. Mike.
So I think for looking at diagnostic accuracy, I think something that I have really almost nothing to do with, but I think is going to be fascinating, is theranostics. And if we figure out what targets are important for a tumor, to do that by imaging, doing a molecular treatment, and then looking at response with molecular imaging, and possibly looking at delivery of what drug based on imaging and fewer biopsies. But that has a lot of development to do yet still. I think that I like the mention of looking at these in research studies because I remember on CNN when they came out with Avastin, were saying we found the end of cancer because we can knock off the blood supply to the tumor. So any hype has to be really critically evaluated and held up to validation. And in some case, it may be the DNA is not important. We have to look at the RNA or the protein or the viruses that are involved or the the gut microflora. So I think TCGA is doing some interesting things where they're looking at, RNA expression, DNA, protein, and methylomics, and trying to correlate all of these. But I think there are some areas, so let's look at like a squamous cell or small cell lung cancer, where we have very little change over many years, and we have no new targets. So there was just, genomic sequencing of the squamous cell lung cancer with new targets potentially available. These have not been tested yet, but I think that is something where if we have sequencing of a number of people, find new targets, and then we can test people, and maybe it's not their whole genome, but test focused targets based on their tumor type, there is a lot of potential to take us from where we've been static for like 20 years to developing new drugs. And for some things that are relatively easy to treat, that there's very high response rate, there may be limited utility of genomics. But in other areas that are complex or that are syndromes of diseases like breast cancer, where it's not one disease but really many diseases, and it's, I think some of the articles said there are 4 types, but of course there's many more than 4 types. And we've known about ER, PR, and HER2 status for some time, but there's all these other types. I think understanding that will really propel us into a better way to treat patients. And also how we design clinical trials. Clinical trials, there will be few of the like multi-thousand patient trials that are not selected. More and more studies are going to be with molecularly selected patients in smaller numbers, looking at larger effect sizes. And I think that will lead to hopefully shorter drug development time, like
more tailored medicine,
and improved patient care, and hopefully higher accrual in clinical trials to answer these very important questions.
Right, excellent. Great contributions from all 4 of our panelists, and I know we've got some questions coming in from the audience. So I'm going to hand the chairman duties back to Eric, and he'll round things out. Eric.
I was going to just first, guys, thanks so much. This has been great. We're gonna go a little bit long here. I know some of you on the call will have to drop off and start seeing patients, but we're going to try to take a couple of these questions that have come in from the group that's been watching and listening in. The first one says, as a grandfather of a 4-year-old boy who, with insensitivity to pain, I would like to know what genome genetic testing is available and helpful in the diagnosis and treatment. So I don't know if that's a question anyone has the answer to, but I'll start, Mark, with you, and we'll go around the room.
So I get consulted about once every 2 weeks on whether, there was a patient with a daughter who had, there was a family with a daughter who had intractable migraines, and they were kind of at their wits' end because they had gone through every standard diagnostic modality currently offered and weren't able to find out anything. And I get questions like this, again, quite often about whether a genome analysis would help. I think in most cases, no, we simply don't know enough about the genome to recommend this in cases like that. I actually just recently had my own genome done from my germline genome or somatic genome from my peripheral blood lymphocytes, which is just a convenient way to sample your genome. And I received from the sequencing lab an Excel file with 23,000 rows in it. And these 23,000 rows documented the differences in my genes between my genome and a reference sequence. And most of, in fact, virtually all of these 24,000 changes were completely uninterpretable. So it's not something you undertake lightly, and that's my recommendation.
Okay, great. And we were just throwing in a related question. I mean, are there high throughput platforms that are out there to query the epigenome?
There are certainly in the research arena, but I don't know of any one who is daring enough to pretend to offer this as a clinical test at this point, in contrast to the genome or exome analysis.
So, anyone else aware of Kent?
They're not ready for prime time.
Yes, sorry, Eric, I agree. Great potential, but I don't see anything of clinical relevance just yet.
Okay. And how about lawsuits? Has there been a lawsuit involving a failure to determine a genetic risk in someone developing cancer or some other condition? I don't know, Mike, if you want to start there. Have you heard of any?
I cannot think of off the top of my head. I think it's there probably have been or will be, and but it's one of those things where often the specter of liability often influences both medical systems and doctors more than sometimes actually what has happened. But I think the potential, again, like genetic counseling, you find a mutation, you don't know what it means. 5 years later, it becomes an obvious, an important target or important gene. What is your responsibility? And I think one thing is you got to spell out exactly kind of the statute of like how long you're going to tell someone about it. And I think the best way I've seen is just saying, at this visit, when we're talking to you, here's what we know. That will change over time, and it's your responsibility to come back to us over time if things come out, because I think it's hard to track, even in a, let's say, a large health system, because people move around so often and change their information. So
there is one lawsuit where a daughter sued her father's oncologist because he had a colon cancer, yes, and that physician did not alert the rest of the family. And so it's not really settled law about whether or not the physician, who had no doctor-patient relationship with the daughter at all, what their responsibility was. But lawsuits are starting to happen.
Eric, Arnie, if I could just state that in the arena of primary care, where all physicians are always concerned about attaining a diagnosis early, particularly in a cancer case, the good news is that most of these things we talked about are not state-of-the-art or standard of care, which is required in any lawsuit. The problem would be that things like BrCA has become close to standard of care, really, out there. So it's just a matter of time, I would imagine, I'm not wishing this, that there'll be a case where a breast cancer will not be found early, and in a woman with a highly positive 3-generational family history, and some lawyer will say, well, was a BRCA test done in this individual, and it was not, and that will become a problem. That's not been happening yet.
Great. So second to last question, how accurate is RNA sequencing in the clinical setting? I don't know, Kevin, if you want to touch upon it, and then everyone else, if there's additional comments, you could jump in.
Well, are you talking RNA sequencing or RNA expression arrays?
The exact question was, the output of epigenomic modifications is altered RNA expression in RNA is quite unstable. How accurate is RNA sequencing in clinical settings?
Well, the RNA can be measured in different ways. I would get it out of the epigenetic context, because we've already just touched on that. I mean, the gene expression panels are widely used in clinical practice and are highly accurate, and the accuracy improves all the time. And as far as the general sequencing accuracy, right now, if you sequence the genome or an exome, you would be looking at, it's about 99.9 or 0.99% accurate, but the software for annotating the variants, the chemistries, they're improving all the time, and the way you get around the accuracy issue is to sequence everybody's genome tens, if not hundreds of times, particularly in a clinical context. So clinical gold standard sequencing would typically be of a much higher stringency than teams would normally do in a research setting. So it can be an issue. There can be false positives and false negatives, but the analytical validity overall is very high and is just only going to get better.
Eric, Arnold Palay, there is an RNA expression test recently been licensed from California to use for stratification of risk of chest pain patients and who should go for invasive cardiac catheterization and who should not. It does not work in the diabetic individuals. How that will stand up to wider usage is unknown, but has become recently approved through Medicare funding. So it's a fascinating area that is just coming to market.
And last question, some folks on the call want to know, how can they get into this area? Are there organizations to outsource the sequencing? And I'll add like a final portion to this question is, are there recent articles, recent places maybe online where our attendees could go and read more up on some relevant stuff as it relates to the topic?
Yeah, this is Mark Boguski. A couple of suggestions. In response to one of the questions, I gave the URL for our Genomic Medicine Initiative training program at Beth Israel. There are links there to sort of foundational papers and resources in the literature, and we also put in some links to the blog post we specially prepared for today's webinar.
This is Kent. There's two good books I could recommend. Eric Topol, who's a leading cardiologist, has written a book called The Creative Destruction of Medicine that has a really good summary of whole genomic sequencing. And the other book is by David Agus, The End of Illness. Both of those, I think, are books by prominent physicians who are academicians who really have a good handle on how all this might play out.
But not as good as the $1,000 genome, Kent, right?
I was going to mention that.
If for the question, if people Google clinical exome sequencing or a phrase to that effect, they'll see many academic clinical centers around the country that are now offering clinical sequencing. If you're talking about a research context, then Illumina has an outsourcing service, which I think is as good as any. Complete Genomics has also been one of the mainstays for whole human genome sequencing, currently being bid for being acquired by BGI, formerly the Beijing Genomics Institute. We wait to see how that shakes out. But there are more and more centers offering exome and in some cases even whole genome sequencing, and I mentioned a few earlier.
Great. So I want to thank everyone. Our panel, Kevin, you guys were terrific. This probably breaks our record for longest overrun webinar in Best Doctors history. So you could take credit in that vein. Thank you to all our attendees for joining. For all those listening on demand, we really appreciate the time you've taken to listen to our sessions. We hope to be providing you more content throughout 2013 and beyond. And as I mentioned earlier, you could also request to receive the links to any of the references that were pointed out by our panelists this morning. So this will mark the end of the call. Thank you all again, attendees, panelists, Kevin Davis, great job as usual. And we will see you soon on another Best Doctors webinar.